Here we are again with news from the website prostatewarriors.com. And I have to say, looking at the stack of research we have in front of us today, it feels like the dam is finally breaking.
Oh, absolutely.
You know how sometimes in cancer research you go through these long, dry spells where it feels like everything is just a minor tweak to an old formula?
The incremental improvement phase.
Yeah.
Yes. It can be incredibly frustrating for patients, for families who are waiting for that big leap forward.
Right.
You see a lot of, statistically significant results that don't actually change the daily reality of the disease.
Exactly. But the sources we're diving into today, this doesn't feel incremental.
Mhm.
We aren't just talking about a new pill that gives you, I don't know, 2 extra bucks. We're looking at a fundamental shift in strategy.
It really is a comprehensive suite.
We've got a massive stack of clinical trials, some major quality of life updates that are actually actionable, and some very futuristic tech that honestly sounds like science fiction.
And if you look closely at the research, there's a connecting thread here. It's the move away from the sledgehammer approach.
Right.
Just blasting the whole body with chemo or hormones and hoping the cancer dies before the patient does. We're moving toward extreme precision.
Precision in how we kill the cancer, yeah. Overcoming that nasty drug resistance,
Yes.
but also precision in how we protect the patient.
That's the key.
Because frankly, surviving the cancer shouldn't mean being miserable for the rest of your life.
That's the takeaway today. It's about treating the disease without dismantling the person living with it.
So for everyone listening, here's our roadmap. We are going to start right in the trenches. A heavy dose of new clinical trials. We're talking trikes for immunotherapy, a way to stop cancer from shape-shifting.
And a safer approach to PRP inhibitors.
Yes. Then we're going to pivot to something that affects the daily reality of thousands of men, a huge breakthrough in managing hot flashes.
And we are not just talking about buying a portable fan. No, we're talking real data. Then we'll break down the WOLVERINE study, which, by the way, best name ever for a trial
It is a great name.
on targeting metastases. And we'll wrap up with some mind-bending nanotechnology that uses the tumor's own acidity as a weapon against it.
It's a packed agenda. So where should we start?
Let's get right into it. The immunotherapy frontier. We're looking at a phase 1 trial called GTB-5550. It just got FDA clearance to launch. Now, immunotherapy in prostate cancer has historically been, well, let's be honest, it's been disappointing.
That's putting it mildly. Prevenge was the pioneer years ago, but it's been lonely at the top. The issue is that prostate tumors are what we call cold tumors.
Cold tumors.
They don't trigger a strong immune response on their own. They're just very, very good at hiding.
They fly under the radar.
Exactly. So to understand why GTB-5550 is different, we have to talk about the bouncer of the immune system, the natural killer cell, the NK cell.
I love the NK cell. Unlike T cells, which need to be, introduced to the cancer, NK cells are innate. They just see something that doesn't look right and they take it out.
They're the security guards that don't need a warrant.
Exactly.
Precisely. They're the first line of defense. But in prostate cancer, the NK cells, they get neutralized. The environment inside a solid tumor is hypoxic. It's starved of oxygen.
Why is that?
Because the cancer grows faster than the blood vessels can keep up.
So it's like a dark, crowded nightclub with no air conditioning?
That is a perfect analogy, and in that environment, the NK cells become sluggish. They literally run out of breath.
They can't fight.
They lose their energy. They can't fight. Plus, the tumor sends out signals to basically shut them down. So you have the bouncers, but they are asleep on the job.
Enter the GTB-5550 trike. The source describes this as a trispecific killer engager.
A bit of a mouthful.
It is, but the mechanism sounds brilliant. It's essentially a 3-pronged tool, right?
Think of it as a molecular multi-tool. So prong 1, it grabs onto the NK cell using a receptor called CD16. It physically latches on.
Like putting a leash on a guard dog so it doesn't wander off.
Right. Now, prong 2 is the energizer. It contains a molecule called IL-15.
Okay.
Usually when NK cells enter that low oxygen tumor environment we talked about, they just fade. But IL-15 acts like a battery pack. It boosts their proliferation and keeps them alive and aggressive.
So even when the oxygen is low.
Even when the oxygen is low. And that's the crucial data point from the preclinical work, isn't it? Even in that dark club of the tumor core, these cells kept fighting because they had their own power supply.
Incredible.
They did. And that brings us to prong 3, the guidance system. It targets a protein called B7H3.
And that's on the cancer?
It's found on almost all prostate cancer cells, especially the nasty metastatic ones that other drugs miss.
So just to recap for everyone, you have a molecule that grabs the killer cell, juices it up with energy so it doesn't pass out in the tumor, and then drags it directly to the cancer cell.
A molecular GPS with a built-in energy drink.
Wow.
And what's really promising is that in the lab, this worked against cells that were resistant to enzalutamide.
So it gets around hormone resistance.
It doesn't care about it. It just cares about that B7H3 marker.
That's huge for men who have exhausted standard hormone therapies. It's a completely different angle of attack.
It is.
Now, speaking of hormone resistance, let's move to the next trial in our stack, the JASPER trial.
This is a phase 1/2 trial coming out of the University of Michigan, and this one is tackling something that sounds like it belongs in a sci-fi movie: lineage plasticity.
Which is a fancy way of saying shape-shifting.
It really is. We hit prostate cancer with potent drugs like abiraterone or enzalutamide.
Okay.
These drugs starve the cancer of androgen, the male hormones it needs to grow. It cuts off the food supply.
But cancer is a survivor. It doesn't just starve, it adapts.
It does. Under that extreme pressure, some cancer cells pull a master maneuver. They reprogram their own identity. They switch from looking like a glandular prostate cell to looking like a neuroendocrine cell.
They basically change their ID card so the drugs don't recognize them anymore.
Exactly. They don't need the androgen receptor, so blocking it does nothing. And once they make that switch, they become incredibly aggressive and hard to treat.
And here's the insight. We've found the engine that drives this transformation.
We have. It's a signaling pathway called JAK-STAT.
JAK-STAT. I've heard of this in relation to arthritis, right?
Yeah.
It's usually involved in inflammation.
Correct. But these cancer cells hijack it to drive their shape-shifting. So the JASPER trial is asking a simple question. What if we cut the fuel line to that engine?
So they're combining enzalutamide, the standard drug,
Mm-hmm.
with Ruxolitinib.
And Ruxolitinib is a JAK inhibitor. It's
Yeah.
fascinating because this drug is already on the shelf. It's approved for blood disorders like myelofibrosis.
I love it when we repurpose things. So the logic is you block the androgen with enzalutamide, and you block the escape route with Ruxolitinib.
That's the synergy. The preclinical data showed that when you use them together, you prevent the cells from using those inflammatory signals, specifically IL-6, to survive and change shape.
You trap them.
You are effectively trapping the cancer in a state where it can still be killed.
It stops the shapeshift before it happens. This is launching now. And for guys dealing with resistance, understanding why the drug stopped working is half the battle. This trial addresses the why.
It's a mechanistic approach to resistance, which is always smarter than just guessing.
Okay, keeping with the theme of smarter, let's talk about safety. We've discussed PRP inhibitors on this show before. Drugs like olaparib.
Right.
They're great for men with DNA repair mutations, like BRCA, but they can be rough on the body.
They can be. The current generation of PRP inhibitors are what I'd call shotguns. They hit the target, PRP1.
Which stops the cancer from fixing its DNA.
Yes. But they also hit PRP2.
And PRP2 is the innocent bystander.
In a way, inhibiting PRP2 is largely responsible for the toxicity we see. The severe anemia, the drop in red blood cells that leaves patients exhausted.
And often requiring blood transfusions.
Right. Which forces doctors to lower the dose, which means less cancer killing. It's a vicious cycle.
You have a drug that works, but the patient can't tolerate it.
Exactly. So enter SPR 1020. This is the focus of a new phase 1/2 trial. It is a next-generation PRP inhibitor because it is highly selective. It's a sniper.
A sniper.
It hits PRP1 but virtually ignores PRP2.
So you get the DNA shredding effect on the tumor, but your bone marrow stays happy.
That is the goal. But there is another feature of SPR that caught my eye, and it might be even more important than the safety profile.
The brain penetration.
Yes. Prostate cancer in its late stages can metastasize to the brain. It's not common, but it happens, and it is devastating.
And the blood-brain barrier is the problem.
It is. It's a protective filter that stops most drugs from getting into the brain. Most standard chemo, even some targeted drugs, they just bounce off the gate. But SPR 1020 is chemically designed to cross that barrier. So if you have a patient with a BRCA mutation and potential brain mets, this could be a game changer.
A cleaner drug that reaches sanctuaries the others can't touch.
Exactly.
It's amazing how much drug delivery matters just as much as the drug itself. Okay, one more trial before we shift gears. P3136. This brings us to epigenetics.
The software of the cell.
If DNA is the hard drive, epigenetics is the operating system telling the computer which programs to run.
That's a perfect analogy. In prostate cancer, the hardware, the DNA, might be fine, but the software gets corrupted. Specifically, proteins called COT6A and KT6B get stuck in the on-end position.
And they start running the grow tumor program on a loop.
Constantly. OP3136 is a KT6 inhibitor. It effectively goes in and forces a reboot. It turns those switches off.
And this is for mCRPC.
Yes, this phase 1 trial is recruiting now for men with metastatic castration-resistant prostate cancer, and the lab data showed it plays nice with docetaxel, the standard chemo.
Synergy again.
Synergy again. It works on both hormone-sensitive and hormone-resistant cancers. So it's another tool in the belt attacking a completely different control mechanism.
Okay, we've covered a lot of heavy science on killing the cancer.
Okay.
But I want to pause and talk about living with the treatment.
Right.
Because fighting the tumor is only half the battle. The other half is dealing with what the treatment does to you.
You're talking about ADT androgen deprivation therapy.
The backbone of treatment.
Yeah.
It wipes out testosterone.
Yeah.
And with that comes the hot flashes. I feel like the term hot flash doesn't do it justice.
No.
It sounds like a minor annoyance, like you just need to open a window.
It really minimizes the suffering. We are talking about drenching sweats, heat waves that feel like your skin is on fire 10, 15 times a day, and crucially at night.
If you are waking up soaked in sweat 5 times a night, you aren't sleeping.
Not at all.
And if you aren't sleeping, you physically and mentally cannot cope with cancer.
Precisely. Sleep deprivation leads to depression, cognitive fog, poor physical recovery. Up to 80% of men on ADT deal with this, and for a long time the advice was just wear loose clothing.
Which is insulting, frankly.
It is.
But this new study, the Alliance A222001 Phase 2 trial, actually offers a real solution. They tested a drug called Oxybutynin.
Now, if you're a pharmacist, you know Oxybutynin as a bladder drug. It's used for overactive bladders.
So how does a bladder pill stop hot flashes?
Well, it blocks a specific neurotransmitter, acetylcholine, that mediates the sweating response. They found that in higher doses, it just dampens the body's internal thermostat.
Let's look at the results because they blew me away. They compared a placebo to a low dose and a high dose. High dose was 5 milligrams twice a day.
And that high-dose group saw a 68% reduction in hot flashes compared to the placebo.
68%. That is massive. And what about severity?
Nearly 80% of the men reported at least a 50% drop in how bad the flashes were. And this wasn't a wait 6 months situation. They felt relief within the first week.
Imagine the impact on quality of life. You go from miserable and sleep-deprived to actually functioning again.
The quality of life scores confirmed that. Better sleep, better mood, better daily function, and the side effect profile was manageable, mainly dry mouth, which makes sense.
It dries you up. But compared to drenching sweats, a dry mouth seems like a fair trade.
Absolutely. And here's the best part. Because this drug is generic and available right now, this is something patients can discuss with their doctors today.
That is actionable intel.
Yes.
I love that. Now, moving from daily management to long-term strategy, the WOLVERINE study.
Published in the Lancet Oncology, this is high-level data, a systematic review, and a meta-analysis.
It focused on oligometastatic prostate cancer. We need to define that. Oligo means few.
Right. These are patients whose cancer has spread beyond the prostate, but not everywhere. It's contained to a few spots, usually defined as up to 5 metastases.
It's this gray area. It's not localized, but it's not widespread. And the debate has always been, do we just treat these men with systemic hormones and wait? Or do we go after those spots?
The whack-a-mole strategy. Metastasis-Directed Therapy, or MDT. The WOLVERINE study crunched the data from 7 trials to settle the debate.
And the verdict?
A resounding yes for aggressive treatment. They compared standard of care alone versus standard of care plus hitting those spots with focused radiation or surgery.
And the numbers are level 1A evidence, progression-free survival.
The risk of progression dropped by roughly half. The median time without the cancer growing went from 21 months with just hormones to 35 months with the added spot treatment.
That is a gain of 14 months, over a year.
Over a year of extra time where the disease is stable. And remember, that's 14 months where the cancer hasn't developed resistance to the hormones yet. You are buying high-quality time.
Wow. And survival.
The 4-year survival rate jumped from 75% to 87%.
So the takeaway is clear. If you have a low number of spots, don't just rely on the drugs.
Zap the spots. Aggressive local control delays the systemic progression. It's a strategy that is becoming the gold standard.
Time is everything.
That's a perfect segue to our final topic, which is about as futuristic as it gets. We are heading to Oregon State University for some preclinical work on nanomaterials.
This is where chemistry meets oncology. It's a new concept called chemodynamic therapy.
Break that down for us. What are we looking at?
It's a nanoagent, an iron-based metal organic framework. But the researchers designed it as a kind of Trojan horse.
Yeah.
It enters the body completely harmless, it's inert, so it floats past healthy tissue and does nothing. Until it hits a tumor. Now, we mentioned earlier that tumors are hypoxic, they are also acidic, they have a totally different chemical environment than healthy cells.
It's a toxic wasteland in there.
Right, and this nanomaterial is designed to react specifically to that acidity. It's like a booby trap that only goes off when the pH drops.
So when it enters the acid of the tumor, it wakes up.
It triggers a dual chemical cascade. It starts spitting out hydroxyl radicals and singlet oxygen. We call these reactive oxygen species, or ROS.
Which are basically molecular shrapnel.
They shred the cancer cell from the inside out, destroying DNA, proteins, lipids. It causes massive oxidative stress.
Of healthy cells next door.
They're fine, because they aren't acidic enough to pull the trigger.
Mm.
In the mouse models, and this was using human breast cancer xenografts, they achieved complete tumor regression.
Complete regression.
The tumors were gone, and crucially, they found 0 side effects in the organs. No damage to the liver, kidneys, or spleen because the weapon only armed itself inside the tumor.
That is the holy grail, killing the bad guys without touching the good guys.
Wow.
And doing it based on the environment of the cancer, not a specific mutation.
It's purely chemical warfare against the tumor's own waste products. It's still early days. This is preclinical, so we are years away from humans, but the concept is incredibly elegant.
It really is. We have covered so much ground today, from tricase, boosting the immune system, to preventing shape-shifting with JAK inhibitors, to sniping DNA repair with selective PRPs.
And don't forget the strategy shift to treating oligometastatic spots aggressively and managing quality of life with repurposed drugs.
If you had to synthesize this into one message for the listener, what would it be?
I think the message is that we are moving from blunt force to smart power. We aren't just throwing chemicals at the body anymore. We are understanding the mechanisms of resistance, the hypoxia, the plasticity, the epigenetics, and we are designing specific keys for those locks.
And sometimes the key is already in our pocket.
That's the most provocative thought for me today. Look at Oxybutynin for hot flashes. Look at Ruxolitinib for the JASPER trial. These are old drugs. A bladder pill and a blood disorder pill.
It makes you wonder.
It does. How many other breakthroughs are sitting on the pharmacy shelf right now, just waiting for someone to connect the dots? We tend to obsess over the shiny new inventions like the nanomaterials, but sometimes the answer isn't a new molecule. It's a new perspective on what we already have.
That is a powerful thought. The cure might be closer than we think. We just need to be smart enough to see it. Thank you so much for guiding us through this stack.
Always a pleasure. There's a lot of reason for optimism.
For all of you listening, remember, knowledge is your best weapon. Keep learning, keep asking questions, stay strong, and fight on.